So I am really excited about our speaker today. I wore red in honor of Dr. Jensen. With us today for Cardiotoxicity of Cancer Therapies, a review for the oncology provider. So welcome, Dr. Jensen. So Dr. Jensen is an associate professor of medicine, pharmacology at the University of North Carolina School of Medicine. Dr. Jensen is a physician scientist with a clinical and investigative focus on heart failure. He has clinical certification in advanced heart failure, transplantation, and spends 3 months of the year as an attending physician on the UNC Heart Failure Transplant LVAD inpatient service. He also directs the UNC Cardio-oncology clinic. His laboratory uses mouse and cell culture models to study cardiac hypertrophy, heart failure, and the molecular response to myocardial injury, including potential injury associated with cancer therapies. So thank you very much for taking the time to talk with us today. Dr. Jensen, outside of your professional bio, is there something unique or personal you'd like to share with our audience today?
Well, you know, I wore Carolina blue today because in part I am a Chapel Hill native, actually. One of the very few folks around here who was actually born and raised and happy to still be here in North Carolina.
Yeah, great. You can tell I am a transplant, not a native North Carolina. So our lecture has poll everywhere. This is a sample of what it will look like. So while I go through a couple more slides, think about our first question, which will be cardiotoxicity as a condition when there is damage to the heart muscle due to a medication or other therapy. True or false? This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. Dr. William Wood and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Dr. Brian Jensen has no relevant financial relationships with commercial interests as defined by the ACCME. Dr. Brian Jensen receives speaker honorariums from AstraZeneca and Cytokinetics. This relationship has been mitigated and has not influenced the planning or implementation of this activity. So you can answer through your poll everywhere, true or false, that cardiotoxicity is a condition when there is damage to the heart muscle due to a medication or therapy. So we'll give them a minute. It looks like 100% are answering true so far. How'd they do, Dr. Jensen?
Very well.
Great. So without further ado, I will hand it over to Dr. Jensen.
Okay, thanks so much. And I'm honored by the invitation to come and speak today and thankful to those of you who took the time out of your busy days to sit through this talk. I'm going to talk about cardio-oncology in a broad way to introduce those of you to the field, those of you who are unfamiliar with the field, to cardio-oncology. I am not going to talk about any of my science. It's true that I do take part in basic science, but you're not going to hear about any of that today. We're going to focus entirely on clinical medicine. And I've made an effort to divide the talk into sort of a conceptual framework for thinking about cardio-oncology and then hopefully a more practical approach to taking care of heart-related issues in the setting of treatment for cancer. Next slide, please. So again, for those who are unfamiliar, cardio-oncology is a field that has been emerging in the past decade or so. I started the cardio-oncology clinic here at UNC about 6 years ago, and I'm still the sole provider here. We see about 90 new consults per year and about 150 to 200 returns. So not a high volume clinic, but enough to make things interesting. So if you Google cardio-oncology, you find what looks like a relatively unsatisfying definition to me. As we go, I'm going to try to build upon this definition and offer you some thoughts about what I think cardio-oncology is, or should be at least. So next slide, please. The other thing you discover quickly upon Googling cardio-oncology is that people do seem to be interested in it. There are programs popping up all over the country. And I think I'm going to provide some statistics that I hope will convince you of the merit of having a cardio-oncology program. Next slide, please. When I'm looking for help understanding something, I'll often go to PubMed as well. And here I wanted to draw your attention to the results by year panel, showing that as recently as 2009, the cardio-oncology PubMed query yielded 3 results, but that there's been a rapid acceleration in publications related to cardio-oncology. The PubMed search, when I did this a little while ago, yielded well over 1,000 publications again. So whatever it is, people do seem to be interested in writing about it, hopefully reading about it too. Next slide. This is a schematic that I'm going to refer to again. This is from a paper by a guy named Javed Moslehi, who was at Vanderbilt and now at UCSF, who's really sort of a thought leader in this field. And the slide begins to lay out the ways in which cancer and heart disease can be related. And there certainly are shared risk factors which inform the relationship between cancer and heart disease, and cigarette smoking would be a prime example of those shared risk factors. I'm going to talk less about shared risk factors today and more about the direct hazards to the cardiovascular system that relate to cancer therapy. We're going to start by talking about cancer therapies that have been used for decades, radiation therapy and anthracyclines. And then we're going to move more into targeted and contemporary therapies. I understand that each of you has a focus within oncology, and I acknowledge that I may talk more about breast cancer than other malignancies, but I have made an effort to discuss therapies that are used in many different types of cancers today, so I hope this will be useful for you. Next slide. So when I think about cardio-oncology, I like to think about it in terms of the patient focus. And there are 3 groups of cardio-oncology patients: the comorbid patients and the survivorship patients. And those are really the 2 largest groups of potential cardio-oncology patients. And as I'll discuss shortly, I would say that the survivorship group is the largest and growing group of these patients. My practice at UNC and the focus of today's talk is going to start with survivorship and then move more towards causal relationship, wherein we'll be discussing the cardiovascular risks of certain cancer therapies. And these patient examples are people whom I've seen in clinic over the years. Next slide, please. So these statistics are a couple of years old. In the next slide, I'm going to show you the most recent year's statistics that have an alarming entry in 3rd place. But for years, heart disease and cancer have been the leading causes of death in the United States. And again, given the prevalence of both of these disorders, it stands to reason that there will be there are people with comorbid conditions, both malignancies and cardiovascular disease. Next slide, please. These are the provisional data for 2020, and I include these not for any particular relevance to today's talk, other than to say that this year, as in previous years, heart disease and cancer occupy the 2 leading spots in terms of causes of death, but simply to point out the really discouraging emergence of COVID-19 as the number 3 cause of death in the United States for the past 3 years. So hopefully we will move past this era soon. Next slide, please. So now we're going to move into the sort of the meat of the talk, if you will. And this portion of the talk is really geared to raise awareness. And one of my goals, not so subtle goals here today, is to raise awareness in all of you that a history of cancer and treatment for cancer inherently increases risk for heart disease, and this is independent of the comorbid risk factors that we've already discussed. So these are data, they're old data, but still important data from the childhood cancer survivor study. So survivors of childhood cancer have a 10-fold increased risk for coronary atherosclerosis when compared with age-matched cancer-free peers, 15-fold higher risk of heart failure, and a 9 times higher risk of stroke. And these risks are particularly high in patients, and these were childhood cancers who received anthracyclines or high-dose radiation therapy. And so in the next slide sets, we're going to focus on each of those 2 exposures as independent risks for developing subsequent cardiovascular disease. Next slide, please. So this is a look at the survivorship issue using slightly different statistics. I want to call your attention to the left-hand panel, which is an age-stratified depiction of the percentage of the United States population that is alive with a previous cancer diagnosis. And these numbers are staggering, I think, in some ways, but really more importantly are a credit to the incredible work that oncology providers do to keep their patients alive. The right-hand panel is, again, I want to call your attention to the fact that this is purely ages 45 to 64, so a relatively limited sample of the population. But it makes the point that while deaths from cancer in that age group are declining over the years, that deaths from heart disease are rising. And one way to view these statistics is that people who previously might have died of cancer, who are being kept alive by the excellent care that they receive, are now increasingly likely to die of heart disease. And so again, this is another way to try to raise awareness of this problem. Next slide, please. So we're going to turn to some disease-specific data. And again, these are not new data, but they're always striking to me. So this is a SEER Medicare database look at a very large number of women with breast cancer, median follow-up of 9 years, and as you can see, and with the exception of women who had advanced stage breast cancer, the most common cause of death in women with breast cancer is cardiovascular disease. It's not breast cancer. And importantly, only 25% of the women who ended up dying of cardiovascular disease in this cohort actually had a diagnosis of cardiovascular disease at the time of enrollment. And I think these statistics, A, are surprising to me, and B, highlight the importance of ongoing follow-up of cancer survivors, women and men both. Next slide, please. So here's our first poll everywhere question. I will let you read it for yourself. Now, Tammy, help me. We're going to get answers now? Excellent.
Yep, they're starting to come through. We're getting a little bit of a mixed response here.
Good, that's what we want.
And people changing their mind too.
Also good.
Yeah. How are they doing?
They're doing great. Nobody's wrong. I'll put it that way. So let's forge on, and the answer is E, all of the above. And so let's explore this a little bit further. So now we're shifting out of a focus on breast cancer and looking instead at survivors of Hodgkin lymphoma. You can see here again, these are survivors of childhood Hodgkin treatment viewed out over a 45-year follow-up. So these are very long-term data. To me, a couple of things are interesting here. These data are stratified by risk to either anthracycline exposure or radiation therapy exposure or both. Two take-home points for me. One is that there is an additive risk associated with exposure to both therapies. Two is that if you look at the curve for exposure to both therapies, that at 30 years post-exposure, the incidence of cardiovascular disease is 50%. That number may not seem all that high until you consider that the people who received these treatments were very young when they did it. So these are people who are developing cardiovascular disease at a very young age, where I would submit that 50 is a very young age. And so they're risks to both exposures, and they are incrementally increased over time. Next slide, please. This is a misplaced slide. I really apologize. We can skip this. I make these points better later. Focusing here on the type of cardiovascular disease that can arise after mediastinal radiation. Again, a little bit of a busy slide, but stratified by coronary heart disease or coronary artery disease, valvular heart disease such as the aortic stenosis in my question, or heart failure. And again, long-term follow-up. But here we've dissected out the various contributions to the overall cardiovascular disease that I showed in the initial slide, and applied hazard ratios for each of them. And you can see that there is a significant increase in risk for each of these types of heart disease after exposure to mediastinal radiation for childhood lymphoma treatment. Next slide, please. Shifting back to breast cancer in an effort to demonstrate that these data are not unique to Hodgkin or unique to children for that matter. This is a Scandinavian study of women who received radiation therapy for breast cancer. Overall, relatively low radiation therapy exposure. And you can see that there is a dose-dependent increase in risk of major coronary events, myocardial infarction particularly. That increases per gray of exposure, and that risk is further enhanced by the presence of comorbid cardiovascular risk factors. And this is a theme that we're going to see throughout the talk, that by and large in cancer therapy associated cardiovascular toxicity, the presence of pre-existing risk factors does predict the likelihood of developing cardiovascular toxicity. And we've seen that that's certainly true in the breast cancer group for radiation therapy. Next slide, please. So how does all this happen? In truth, the biology is not worked out as well as it should be. But the one sort of central component to all this, and this is about as far in the science as I'm going to go today, but endothelial injury is really a central component of the pathogenesis of radiation therapy. And because endothelial cells are important in lining the coronary arteries and important in lining the valves, those tissues, the coronary arteries and the valves, are particularly susceptible to injury. There is also an unfortunate predisposition to constricted pericarditis from radiation exposure, as well as restrictive cardiomyopathy. And so those of you who selected any of those options in the initial question were absolutely right. Unfortunately, all of these, the pathobiology involves all of the tissues in the heart. Next slide, please. So here is a table listing risk factors for radiation-related cardiovascular disease. And some of them are just as you would think. Anterior left chest irradiation, where the heart was in the field, high cumulative dose or high exposure. Lack of shielding, which is less and less of a problem, and there are are some real advances in heart-sparing radiation therapy in recent years that hopefully will reduce the incidence of this problem in years to come. But also concomitant cardiovascular risk factors and the concomitant use of chemotherapy, in particular anthracyclines. Next slide, please. So, why do we use radiation therapy? This is obviously a rhetorical question for this audience. We use radiation therapy because it's beneficial. It extends survival in many contexts. And that point is made very clearly here in this paper. But one thing I did want to point out is if you look at the middle panel, and again, breast cancer data, the addition of radiation therapy in this trial did improve overall survival. But if you look at the cancer-specific survival and compare it to the survival of all-cause survival, that the lines are much, much closer in the all-cause survival. And I think we can extrapolate from other data sets to say that a primary reason for that is that cardiovascular death is increased in patients who have received radiation therapy with the heart in the field. Next slide. Let me actually, Tammy, I'm sorry, could you go back one slide, please? There's one thing I wanted to say before we moved on, and that is that there are not clear guidelines for how we screen for cardiovascular events in cancer survivors who have received mediastinal radiation. The clearest articulation is from a society that oversees echocardiograms, and so they recommend echocardiograms every 5 years in patients who have received radiation therapy with mediastinum. I don't know if that's the right interval or not, but the take-home point that I would like to leave with you is that in a patient who has received mediastinal radiation therapy, if they have a complaint that could be referable to the heart, I would encourage you to view the radiation therapy as an increased risk factor. So lower your index of suspicion that the heart might be involved and be quicker to use diagnostic modalities to look at the heart, such as echocardiogram or a stress test. Okay, now next slide.
So our next question, anthracycline-induced cardiotoxicity is blank with contemporary chemotherapy regimens and typically occurs blank time after treatment. We have some mixed answers coming in. Looks like our most popular answer is rare and years after treatments.
Yeah, so let's move on. The answer is common and months. And I know that's a bit of a provocative answer, but I'm going to provide some data that I hope will back that up. So first of all, just in all comers, heart failure is more common in breast cancer survivors, and that risk is enhanced by anthracycline exposure and by comorbidities. Again, a recurring theme here. Next slide. Anthracyclines, for this crowd, I don't need to introduce this material to this crowd, but I think it's always fun to remind ourselves of how they got the names that they have. So adriamycin is so named because it was isolated from a streptomyces bug that was initially found near the Adriatic Sea. Doxorubicin and daunorubicin are so called because they are characteristically red or rubeous in color. As you all know, they're highly effective. The mechanisms of anthracycline cardiotoxicity, honestly, are multifold and complicated and go beyond just free radical production and oxidative stress, but I'll spare you all that today. Next slide, please. So these are relatively recent data looking at what is clearly true, which is that anthracycline cardiotoxicity is a dose-dependent phenomenon. there is an inflection point at roughly 250 milligrams per meter squared doxorubicin equivalent exposure, but the risk doesn't start there. It starts at much lower exposure. And I unfortunately see plenty of patients in clinic who have received less than 250 milligrams per meter squared of doxorubicin equivalent anthracycline. Next panel, please. These are old data suggesting that much of this disease is late onset. I think the more that we learn about this problem, the more we learn that in fact much of it is actually early onset, occurs within the first month or year certainly after treatment. And the older data that suggested that it was a late onset problem were more of a failure of surveillance and limited imaging technologies than they were of actual biology or pathobiology. Next slide. So this is a study that was done by a guy named Greg Hundley, who was at Wake Forest at the time he did this study and is now up at VCU. They used echocardiogram and cardiac MRI to look at a relatively small number of patients who were getting anthracycline-containing chemotherapy for breast cancer or hematologic malignancies. And there is a very clear, the numbers are small, the decrease in ejection fraction is small, the rise in global longitudinal strain is small, but clearly statistically significant, suggesting that some degree of injury to the heart associated with anthracyclines is actually common. The data in the bottom left panel are data from a paper that we published looking at a different data set from Greg Hundley, suggesting that the appearance of this cardiac dysfunction can occur as early as a month after initiation of therapy. So again, that whatever is happening, it's happening fairly early. Thankfully, it's typically quite mild and often self-resolving, but it's not rare. Next slide, please. So how do we detect it? And one of the points that I'm going to try to make here is that we should do a better job of early surveillance, that we do well when we image early and we detect disease early. The most common way to do that is with echocardiography. The best way to do it is cardiac MRI, but who has access to a high throughput cardiac MRI scanner? I certainly don't. There's been some thought about using cardiac biomarkers like troponin or BNP, and the data on those are inconclusive. There are some somewhat persuasive data that I show below, but these data have not been replicated in other trials. So in general, we don't use blood biomarkers to detect anthracycline cardiotoxicity. Next slide, please. There are data, however, that if you identify anthracycline cardiotoxicity early in the form of a decreased ejection fraction, that early initiation of therapy greatly increases the likelihood of full recovery of ejection fraction. In the panel on the left makes this point in a fairly stark way. Now, I will say that I have most certainly taken care of patients who presented beyond this 6-month interval in whom we were able to initiate ACE inhibitors and beta blockers and who did end up recovering cardiac function. But I think that the point here is still a good one, that the earlier we catch it, the higher the likelihood that we can reverse the cardiac dysfunction. And so this is data like these and others are driving the new recommendations, which is to image patients within 6 months of completing their anthracycline-containing chemotherapy regimen, most commonly with echocardiogram. Next slide, please. These are the most recent sort of comprehensive published guidelines, and I put them up to identify some high-risk features, again, greater than 250 milligrams per meter squared or high-dose chest radiation. But again, I think the next iteration of these guidelines, I'm fairly confident after speaking with the people who are writing them, will suggest that we should image earlier and that 6 months, within 6 months after treatment is going to be the optimal. interval, and then one again, another echo again within 2 years after that, and that instituting that more aggressive surveillance strategy is going to catch a lot of disease earlier and enable us to intervene earlier and improve outcomes in the long term. Okay, and so that's all I have on anthracyclines. I want to talk now about targeted therapies. Again, with apologies, more breast cancer. This is a particularly common problem, though. Goes without saying, HER2 antagonists, beginning with trastuzumab, are blockbuster drugs and revolutionized the treatment of HER2-positive breast cancer. The preclinical studies did not suggest that there would be any problem with the heart associated with these drugs. Next slide. But there is, and it's, again, thankfully relatively mild and reversible, not always, but often. But real-world studies have shown an incidence of, up to 20%, and I'm going to show you a clinical trial shortly that suggests perhaps even higher, of patients who receive trastuzumab who have some decrement in their ejection fraction. The mechanisms here are fascinating to me, but I'm not going to belabor them now for you. Happy to talk about it over email or after I'm done if you're interested. Next slide, please. So I put this slide up for two reasons. One is to begin to address what we should do about this issue. And two is to show some clinical trial data suggesting that the frequency with which this is a problem. And so this was a trial that was designed to ask whether we should give patients who receive concomitant anthracycline and trastuzumab prophylactic ACE inhibitors or beta blockers. And as you can see, those who received anthracyclines did have some protection from the use of ACE inhibitor or beta blocker. Those who did not, and this is where the field is moving in my understanding, really saw no risk reduction from the use of either of these drugs for primary prevention. 2 points to make. One is with reference to treatment. I'm not aware of anyone who routinely uses ACE inhibitor or beta blocker up front as primary prevention. Two is, if you look at the numbers of women who had a drop in ejection fraction of 10% or greater, in the placebo group, in the no anthracycline group, 25% of them had a drop in EF. So this is not a rare problem. Next slide, please. So these are relatively dated guidelines, but the guidance is still the same. That is that, we tend to do echo every 3 months. I will say that in particularly high-risk patients or patients who have dropped their EF on Herceptin or HP, we'll do it after 2 cycles or every 6 weeks. And that if the EF drops to below 45%, you probably should pause therapy and start cardioprotective meds. Above 45%, and you can usually treat through safely. And I would say that in almost all instances, if the EF does drop and you pause therapy, you can safely re-challenge once they're back on ACE inhibitor and beta blocker. And again, I want to be very clear that the goal of cardio-oncology is not to disparage the risk of cancer therapies, but rather to try to facilitate cancer therapies. I do know that the data are very clear that interruption of trastuzumab therapy confers worse outcomes. And so by all means, the goal is not to stop therapy, but to help to support ongoing therapy and to get women through their prescribed course. Next slide, please. Now we're going to move into a bit of a potpourri. So those were the sort of the longest pieces. Now we're going to move through a couple of different therapies about which I'm asked questions fairly routinely. So endocrine therapy is an interesting one. There is a body of literature that suggests that aromatase inhibitors increase the risk of cardiovascular disease. And that but the data from that arise from trials where aromatase inhibitors were compared with tamoxifen. If you compare aromatase inhibitors to placebo, there's really no difference. So that the aromatase inhibitors don't inherently increase risk of cardiovascular disease. A more appropriate interpretation of these results is that tamoxifen actually offers some protection against cardiovascular disease. And so in patients who have pre-existing coronary disease or cerebrovascular disease prior stroke, may be better to go with tamoxifen. But even if you choose an AI, the risk is not particularly high. Next slide. Conversely, there is a risk of venous thromboembolic disease that's higher with tamoxifen than with AIs. And again, if you have a patient who has a history of VTE, maybe go with an AI instead of tamoxifen. But again, the risks are relatively modest. Next slide, please. So I want to talk about kinase inhibitors, and this is a particular interest of mine scientifically because I study some of these pathways in the heart. I want to start by talking about VEGF signaling pathway inhibitors. This is a relatively dated slide, so you see some drugs that are familiar to you. There certainly have been others added to this list since then, but hypertension is a significant problem in patients who get inhibitors of the VEGF signaling pathway, and it largely has to do with blocking down nitric oxide production. Next slide, please. Again, these are old data using, actually most of these drugs are still in use. But again, any of you who have taken care of patients using these drugs have undoubtedly seen this issue. Thankfully, it's usually manageable. Frighteningly, there are data that suggests that the higher you drive somebody's blood pressure with a kinase inhibitor, the better the outcome is in renal cell cancer. Next slide, please. And again, here some numbers regarding incidents that are a bit more contemporary, and a reminder that the risk factors for developing this toxicity are the same risk factors that are present for developing cardiovascular disease of any kind. Next slide, please. So here are some guidelines as to what you should do about it. And these guidelines are available online. They're suggesting here that we're treating to a target blood pressure of 140/90. That's more lenient than the current ACC/AHA guidelines for hypertension, which target 130/80. This flow sheet suggests using the JNC 7-8 guidelines. They regard thiazide diuretic, ACE/ARB, or calcium channel blocker as equivalent. I think there's some more contemporary data that suggests that a calcium channel blocker is probably the best first choice agent for patients who develop hypertension on VSP inhibitors. Next slide, please. We're going to skip this one. Next slide, please. Okay, so somebody told me that EKGs can be fun. This is a little bit esoteric, but this one, answer to this question requires knowing what the EKG is showing you, which is a little bit small, and then knowing which drug can cause it.
You're really challenging us.
Yeah, so I gave you a couple of layups for the first question, so I thought I'd put something really hard out there.
Yeah.
But again, somebody told me that EKGs were of interest. Yeah, so let's just, I'm just going to give it to you because this is esoteric, but if you use this drug, you may see this, and it's important. So this is ibrutinib. This is atrial fibrillation. So atrial fibrillation is a common cardiovascular disorder, and it's the sort of thing that's relatively straightforward to recognize on an EKG. This is a completely irregular pattern without any P waves before the QRS. Ibrutinib causes atrial fibrillation, and the major problem with that is that atrial fibrillation increases your risk for stroke, and we anticoagulate people who are in atrial fibrillation. but we cannot anticoagulate people who are taking ibrutinib because ibrutinib increases bleeding risk. And so I bring this up only because if your patient who's on ibrutinib happens to develop atrial fibrillation, it might be worth thinking about a different agent. Unfortunately, this is a sticky problem. Next slide. Checkpoint inhibitors, arguably the most important recent development in treatment of, an expanding number of malignancies. We're de-restraining the immune response to tumor in incredibly effective ways. Next panel, please. There are, again, as any of you who have used checkpoint inhibitors know, a number of toxicities, most of which collectively are quite manageable. There is a really scary cardiovascular toxicity, which is myocarditis, where you get a clonal expansion of de-restrained T cells primarily in the heart, and that causes an inflammatory response in the heart, which thankfully is quite rare, but can be fatal. And so want to make sure that you're aware of it. Next slide, please. This is just a histopathologic example of what this can look like. In panel A, I'll simply say that there's very little healthy myocardium in that sample. That's mostly T cells, and that's a bad situation. Parenthetically, anytime you see the heart as part of histopathologic presentation, the outcome was not good. Next slide, please. So it's rare. I mean, the incidence is likely around 1%, but the case fatality is high. So, almost half of the people who develop checkpoint inhibitor myocarditis die. And these are relatively small numbers, but it seems that there might be a predilection in older women in particular, but I think we have more to learn about this problem. Next slide. So how do we approach it, right? So this is a low frequency event, thankfully. But I think, as I said before, if I want to leave you with anything, it's an awareness of the problem. And so if a patient who's receiving checkpoint inhibitors develops symptoms that might be referable to the heart, chest pain, palpitations, new onset shortness of breath, I think it's worth undertaking an evaluation. And the elements of that evaluation are here. I would say that an EKG would be a great place to start. Blood work, looking for troponin. And if there's still, ongoing suspicion after that, some imaging tests. Echo, which is readily available, but MRI would be the definitive imaging study. Next slide, please. So this would be a characteristic finding of myocarditis. And this is a finding that I would want you guys to be aware of. ST elevation, so elevations in the ST segments are always concerning in EKG. Here they're present in many different leads, and that's sort of the nature of myocarditis. It's very diffuse. But this would be a finding that would warrant immediate referral for further evaluation in a patient who is getting checkpoint inhibitor. Next slide, please. There's some data that suggest that, we use immunosuppression to treat checkpoint inhibitor myocarditis, and this is based on data for treating other types of myocarditis. And again, some of you may have heard about the, again, thankfully, extremely rare problem of myocarditis as it relates to COVID and vaccines for COVID. But we use high-dose solu-medrol. There is a relatively recent paper suggesting that abatacept is also good treatment for checkpoint inhibitor myocarditis. But it's otherwise largely supportive, and I think critically, though you can treat through many of the adverse effects of checkpoint inhibitors, this is not one that you can. So if a patient does develop checkpoint inhibitor myocarditis, it unfortunately necessitates cessation of therapy. Next slide, please. Okay, so moving on again, just to talk a little bit more about EKGs. This is a less sort of pressing and urgent problem, but this is a thorn in many of your sides, I'm given to understand. I have been part of a project with some friends here at UNC, led by Josh Seidner. I'm going to show you a little bit about that in a second. But what do we do with QT prolongation on treatment in cancer patients? This is a long list of drugs that are used to treat cancer that can cause QT prolongation. In the right panel, I've included drugs that are not cancer drugs per se, but can be used to treat cancer patients who are on treatment for cancer. All of these have been demonstrated to increase the QT interval. Next slide, please. So this is a sort of an op-ed, basically, that we published in JCO a couple of years ago with Josh as the senior author. Josh and his colleagues have become increasingly frustrated with figuring out how to effectively measure the corrected QT. And it turns out, I mean, the conclusion of this editorial, which was a ton of fun to write, is that the most common formula for correcting the QT interval, which is necessary because the QT interval inherently varies with heart rate. The most common formula is the one on the top, the Bizet's formula. That's what most of your EKG software spits out. It turns out that Bizet's formula is almost wildly inaccurate at high and low heart rates. And again, high heart rates are not uncommon in cancer patients. And that we advocated in this editorial, and our hospital subsequently changed the software platform such that it uses Friedericia or one of the other correction formulae. I recognize that you guys are not going to be in the business of measuring and calculating QT intervals and QTCs, but I would say that if you ever are encountering a question about whether or not it's safe to administer a drug to patient, there is an online website called MedCalc or MDCalc that will allow you to use either of these more accurate formula, the Friedericia or Framingham, that all you have to input is the QT interval and the heart rate, and it will calculate it for you, and that those are going to be, the Friedericia and Framingham, are going to be more reliable than Bizet's. And so we call those QTCF. And so we initially tried to title this editorial, What the QTCF, but they didn't go for that. So this is what the title ended up being. Next slide, please. So this is an example of QT prolongation. And the eyeball test for QT prolongation is if the QT interval here, I wish I had some digital calipers or something, but if QT interval is more than half of the interval between the R waves, if you look in lead V1 here, you can see that the QT interval is really almost 2/3, 3/4 of the RR interval here. And this is scary because this really is a setup for ventricular, potentially life-threatening ventricular arrhythmia called torsade de pointe. Next slide. My last slide. So a summary. I showed you this slide up front, and I used it as a way to introduce you to cardio-oncology. I want to here use it as a way to emphasize some of the take-home points here. And this is Javed, my friend Javed, who wrote these guidelines. This is his conception, but for me, I think the most important one of all of these ABCDEs is awareness, and that is, for those of you who are taking care of either cancer survivors or people who are on active treatment, I think that an awareness of the potential complications of therapy is the first and most important step towards making a diagnosis with referral, as needed. And I'm certainly happy to help with any patients whom you see, either, lifetime through my email, which is here, or through referrals to the cardio-oncology clinic. So I will wrap up with that, and I'm happy to take any questions.
So you can submit questions through poll everywhere, and we can ask Dr. Jensen. You have some other slides here.
Yeah, that's just backup slides in case people had any interest.
Okay.
Yeah.
Let me just move to the slide so we can pull up some questions. Yeah, go through poll everywhere, type your questions. While we're waiting for those to come through, we give a lot of bevacizumab in my group, and now with bevatizo being our first line HCC, we give a ton of bevatizo. So I'm doing a whole bunch of hypertension management and kind of struggle, and I've asked family, primary care providers to help, and sometimes getting people up to triple therapy. So, I mean, I guess my question for you is, we always start off with a calcium channel blocker. Is that the right move? Just keep escalating? Are those patients that, am I under referring to you and accessing my resource in you?
No, I mean, it sounds like you're taking exactly the right approach, which is to say that if I were to see them primarily, I would start with the calcium channel blocker and then, in what ends up being on discouragingly quick succession, getting them on an ACE or an ARB and then a thiazide diuretic. It often takes all of that and sometimes more to knock down the high blood pressure. I would say, of course, I'm happy to see these folks, particularly if we've gotten to the point where the primary care provider feels uncomfortable in managing the high blood pressure. Yeah, feel free to reach out.
Great, thanks.
I'm not surprised to hear that you're having this problem, though.
Yeah, and the amount of bevatizo going on right now is. Yeah.
I mean, and again, this is the cardio-oncology is not about wagging a finger at cancer therapies. It's about how can we combine our expertise to get people the treatment that they need.
Yeah, absolutely. That's what triggered me to think, because sometimes we've had to hold Bev for a while, because of this, and yeah, stay tuned. I'll be reaching out for my more challenging cases.
Yeah.
Any questions for Dr. Jensen? We have about 5 minutes left. I'm looking in the chat. Oh, that's just reminding people.
Hey, Amy, this is Tim, and we still have not received any questions, but we are monitoring, and we'll go ahead and bring those up on the screen as soon as we receive any.
Okay, great.
Yeah, and again, I'll just encourage people, whoever's out there, questions by email. I'm in my email every day.
So we do have a question coming through. In your opinion, is there an EF threshold for initiating TKI therapy, or do you recommend serial echo to monitor?
Yeah, so it's a great question. I mean, there's no there's no evidence-based threshold on which to base this recommendation. I would say that in all of these cases that this is involves an assessment of cumulative risk and benefit, and that if there's a patient who has a low EF who would clearly derive benefit from kinase inhibitor therapy for their malignancy, in almost all cases, I'm going to say, yeah, let's move ahead, because the malignancy is the greater threat to this patient's survival than the theoretical risk of worsening their heart failure. I do think, though, that those are situations in which we monitor more frequently, and those are people. The particularly high risk on treatment people are folks that I always welcome seeing in clinic. I do my very best to get them in an expedited way, so I can do what I can to help to back up the therapies with cardioprotective medications. If a patient has an EF 20 to 25%, and they're very sick with heart failure, it might be worth an overall goals of care discussion. But short of that, I think it's, in almost all cases, I'm going to advocate trying the therapy with close monitoring.
Great, thank you. And I do vouch that you are extremely responsive for those more acute cardiac things that are happening in our, cancer patients getting outpatient treatment. So Thank you. No more questions coming in. Thank you. This was a really great talk. We appreciate you sharing your expertise. I will move through a few of our slides. So thank you to the UNC Lineberger Cancer Network and our telehealth team. Without them, this would not be possible. There's a lot of behind the scenes stuff that they do to make this work. So thank you to Tim Poe, Mary King, Venia Bjord, John Powell, Oliver Marth, Jason Taylor, and Andrew Dodson.